my side, Dr. Krishnamurthy Garu and Dr. Aditya Murthy Garu and Vivek sir to please come on to the stage. I know it's just. Venugopal Garu, thank you so much for having spent these 2 days with all the children. And thank you so much Venugopal Garu once again. And may I request our Medical Superintendent Garu, Dr. TVSP Murthy Garu, to please come onto the stage and please. Sir, a small fill station for you. No. And again may I request the 3 gentlemen to again come and. Please sit.
ఓపెన్ అవుతుంది చెక్ చేశాను. షార్ట్ రన్ అవుతున్నప్పుడు ఈ లోపల నెక్స్ట్ షాట్ ఏది ఉందో అది రెడీ పెట్టేసుకుని ఇక్కడ ఆయన వచ్చినప్పుడు ఆటోమేటిక్గా ఇది కొట్టేస్తే అయిపోతుంది. ఫ్రీ ప్లాన్
And
కూర్చోలేం ఏం లేదు. నెక్స్ట్
I would like to acknowledge the presence of a very good academician, Dr. K. Venkatraju, and I request him to please come onto the stage and accept the small felicitation from all of us. Please, may I request Dr. Anantanag and Dr. Raviraj to please come on stage. Ramareddy garu, Raval Paiki, Mire, Ren sir, Ramakant garu, Sir Abhinandan garu, please come. So we will, thank you so much. So we will continue with the academic session. Thank you.
ఎవరు లేనప్పుడు ఆడియన్స్ చూడొచ్చు.
I now take the privilege of introducing Brigadier Dr. Professor TVSP Murthy Sir, MBBS, MD, MNAMS, PDCC Neuro, PDCC Critical Care, FICA, FICCM, Clinical Fellow, Liver Transplant Anesthesia and Liver Intensive Care, UK, Instructor, CTLS, BLS, ACLS, BCLS, CCLS, ATLS, PG Examiner, Delhi, Lucknow, Pune, BHU, Gujarat and NTI University, NCI and DND Inspector and Examiner, DM Examiner, AIMS, SCTIMS, Publications 75, Presentations 130, Editorial Board Member and Peer Viewer, UA, JACP, MJAFI, and JNACC.
Good afternoon everyone. My name is Murthy. I practice critical care. Basically I'm an anesthetist. I've been little elated about being associated with the field of dentistry for 2 reasons. A small liking for it. Above all, my son is a dentist. He is a prosthodontic surgeon, product of A.V. Shetty and KMC Manipal. And my daughter-in-law is a faculty in endodontics over here. I've been asked to discuss something which is very dry. Nobody likes it. And that's it, fluid and electrolyte balance. In our formative careers, when we do our formal education in the medical field, this is one subject which is not usually read properly, and some fluid we all give, and this thing comes into the main purview of this branch of dentistry, that is the oral and maxillofacial surgery. I had wonderful association with this branch throughout my armed forces career. We did a lot of, you name a surgery, we did that in armed forces, especially during Kargil operation. Without much ado, fluid and electrolyte balance. It will be very interesting if you people understand a little bit about it, so that you yourself can be the master of your case and not be dependent on anyone as far as your management is concerned. All human beings, I will be talking about adult cases. I am not going into the subspecialties of pediatrics, geriatrics, pregnancy, trauma and burns. You as maxillofacial surgeons, budding surgeons, will be associated with a lot of trauma where fluid balance is very important in your career. To recapitulate, total body water is about 70%, on an average about 50 to 60% of the total body weight. Intracellular fluid, it consists of intracellular and an extracellular component in the proportion which is shown over here, intracellular having more, and extracellular is divided into an interstitial which is little less of 15%, and an intravascular component which is very important. It's instrumental in shifts of fluid volume to a large extent, though it occupies only 5%. And that's the diagrammatic representation of the intracellular, the interstitial, the transcellular, which amounts to only about 2%, and the remaining, which we call it as a plasma. In young adults, the total body water accounts for about 60% of the total body weight. An average adult female it's about 50%, so that's why it varies somewhere between 50 and 70%. The highest percentage is found in newborns, which is approximately 80%, and it decreases as age advances and remains fairly constant later. There are certain important things. I don't want to go into the details of what's a cation, what's a anion, but the important fluid components like plasma, interstitial and intracellular components, two categories are of vital importance. One are the cations and the other one is the anion. In the cation part, we have the sodium and the potassium, which are important. The rest of them are insignificant, but they play a role when other things go haywire. And the most important thing is the sodium part, which is to the tune of 140. Whatever I say, it is to be addressed in the units of milliequivalents per liter. And anions, the chloride, the bicarbonate, sulfate, the other part form the important part of the anion, and the chlorides, it's 103. These are the two important giants you got to remember. The distribution inside the body is basically three broad categories. Depending upon the changes in the volume, you can have a fall in the volume in the form of a hypovolemia or a hypervolemia, changes in concentration, whether a particular solute or an anion or a cation, whether it is more than required or less than required, resulting in changes in the balance. What balance is? The acid-base balance. And that can give rise to deleterious effects on the internal milieu of the human body if it is not addressed well in time. The water gain and the water loss is usually compensated and balanced throughout the 24 hours into 7 into 365, until and unless there is a disease process which upsets the balance. And the gain is because of these roots, and the loss is because of these roots. The deficit, if some volume deficit occurs, it enters into the terminology to be called as dehydration, and it's usually depicted in the extracellular fluid volume. That's the part which usually reflects out in the form of dehydration if there is a deficit, and resulting in hypovolemia. Usually it is a isotonic dehydration where there is loss of water and electrolytes and giving rise to a deficit. We term this and classify this into three broad categories, not really strictly as per the rule of thumb, but generally we classify whether the deficit is mild, moderate and severe depending upon what is the percentage of body weight loss that is taking place, be it any etiology, and then we call it as, if it is more than 2%, more than 5% and more than 8%, to be classified as mild, moderate and severe. Now, most of the important causes for the volume deficit are when an individual doesn't take. He doesn't take on his own, or is not taking because of a disease process, or he has been instructed not to take for some reason. In that, it's nil by mouth, dysphagia because of any reason, tube feed individuals, and impaired thirst mechanism because of some pathology. Excessive fluid losses in the form of vomiting, diarrhea, fever, continuous GI suction. It does happen in the medical field due to various reasons. Blood loss because of a trauma, or he has lost quite a significant amount of fluid in the common category of burns. Now, how do you assess? If somebody is having a volume deficit, how do you assess them? History of the recent input and output, if you know, you can fairly arrive at a conclusion that there is a deficit. The vital data which you and me are supposed to have in the normal brackets, like the heart rate should be so much range, your blood pressure should be so much range. These are the two important indices which reflect the volume status of the individual. In that case, you will have a variation in the heart rate and blood pressure. If you really measure someone, which is seldom done, then you will know the difference. The skin turgor is an excellent reflection of the volume status, more so in the pediatric age group. Mucous membranes, if you see the tongue or oral cavity, oral mucosa, you will come to know that the individual is deprived of fluids. Mental status and lab analysis, very, very supportive in trying to arrive at a conclusion. The physical signs, in a case of hypovolemia or a hypervolemia, they're very glaring. It's all book written picture on the face. You have poor skin mucous membranes, dry axilla, flat neck, tachycardia, orthostatic hypertension, weight loss, sunken eyes, azotemia. Usually azotemia is not seen immediately, but it gets reflected after a latent period of at least 4 to 6 hours. And fall in urine output. And if it is hypervolemia, if there is an increase in the fluid more than the required, that can be shortness of breath because of most of the fluid gets accumulated in the lung, in the extravascular lung compartment, and that can give rise to shortness of breath because of the waterlogging state which takes place in the lung, and it impairs the ventilation perfusion at the alveolo-capillary membrane, giving rise to hypoxic features. If you see the neck, today most of you had seen the workstation of cannulating the neck. I hope you all seen yesterday and today. In that, there is the jugular vein and that reflects the volume status of an individual. That's a very good denominator to find out whether the individual is adequately hydrated or not. And in cases of hypervolemia, one of the clinical indices is there is a distension in the jugular venous. But mind you, that's not a foolproof sign to tell that individual is hypovolemic. There are indications where the jugular distension is there, but the individual is not hypovolemic. Let's not go into the details of it. But a hepatojugular reflex, ascites, this is more important. Pitting edema and weight gain. The common lab tests which we do trying to evaluate our clinical findings, our suspicion that somebody is hypovolemic or hypervolemic, are study the electrolytes, that is BUN, not SUN, hematocrit, urine electrolytes, and 24-hour urine for creatinine clearance. Actually, you don't require to do such sophisticated workup to tell somebody is hypovolemic. Clinical profile is much more enough, and it is fairly highly sensitive and specific. In the same parameters can be studied to again say that whether are you on this end of the spectrum or the other end. The most important the element as far as the total body water or fluids inside the body are concerned, electrolytes, is sodium. It's always sodium, sodium and sodium. And the next most important, which we are supposed to know, is potassium. And they have a very little margin of play, especially with potassium, and anything which is going a little haywire than the margin gives rise to deleterious effects on the human body. Now the normal sodium levels is somewhere between 130 and 140. Anything less than this and more than this is inviting trouble. Hyponatremia, we call it anything less than 135, 130. Clinically, they may not show any clinical signs, but as the numbers dwindle down to less than 125 and so, then we keep seeing the clinical features. Acute symptomatic hyponatremia usually does not become clinically evident, that's what I'm telling, until and unless the levels plummet to less than about 130 or 125. And chronic hyponatremic state, they usually remain asymptomatic. There are certain conditions who are chronically hyponatremic. It doesn't say that they are fluid abnormal balancing. So in these cases, you may not visualize, or you may not, or the individual may not exhibit all the clinical signs which have been described. Serum osmolality is the lab test which is most critical for the diagnosis of hyponatremia, which is seldom done in clinical practice. It's only of theoretical importance, and that will be a gold standard to tell that the individual is definitely having a hyponatremia. Now there are two things which you people should remember. One reading is not sacrosanct to tell that somebody is abnormal. Please don't go by one lab reading, even if it is the best of the labs in the world. You should go for a serial assessment and try and rule out a dilutional factor. The same element in the total body sodium must be normal, but because of a dilutional factor, you may read it as an abnormal low value. So don't jump on a conclusion if somebody is 125. Don't jump on a conclusion that somebody is abnormal. Suppose you land up and probably are trying to fit somebody into the square of hyponatremia. It depicts on various systems. Human body is such a wonderful structure. Anything going wrong is depicted somewhere for you to pick it up. The body keeps telling the telltale signs that this is the abnormality. It's you who should have a high degree of clinical suspicion to actually arrive at a possible cause. Now, central nervous system, the individuals have headache, confusion, and again I want to reiterate that this is not the case for all hyponatremics, but usually a hyponatremic behaves in this way. And if you do not treat it, it can land up in seizures, coma, increased intracranial pressure, so on and so forth, musculoskeletal weakness, fatigue, GI, anorexia, vomiting, hypertension, bradycardia. Most of the tissues, they have lacrimation, salivation, and there will be less of output as far as the renal system is concerned. So if any individual shows these signs, then think of that this particular element is less than the required numbers and see that you take measures to correct it. And if it's on the higher side, again it is less. See, mind you had seen over there seizures, coma, irritability, restlessness. So the picture is more or less same for either a decrease or an increase. So clinical profile gives you a clinical suspicion based on the telltale signs of the history and your clinical findings, and you should be very careful in trying to either label the individual either an increase or a decrease and take remedial measures accordingly. Most of the things, they are the abnormalities. Now we got to see are normal, ISO, or above normality of the sodium. So if hyponatremia, if it is isoosmotic, the etiology is usually that there is a lot of isotonic infusions. It could be a lab error. Most of the times, that's why I said that don't jump on a conclusion of a single lab report. If the patient is fine, don't you ever treat the lab report. In such cases, correct the lipids and protein level, because in pseudohyponatremia, hyperlipidemia and hyperproteinemia are one of the causative factors to tell you that it can give rise to a hyponatremia. If it is hyperosmotic, think of hypoglycemia and hypertonic infusions, which can happen in certain conditions like trauma or a diabetic or a low glycemic levels. In such cases, you can have a hyperosmotic hyponatremia, and when you do the corrective measures, or a hypoosmotic, you check for the urine. That's the best way to check it, and you see for the urinary sodium, if it's more than 20, it could be a renal loss or an adrenal insufficiency or too much use of diuretics. For some reason there is too much use of diuretic therapy. And if it's less than 10, then you think of extrarenal causes like vomiting, skin loss, heat strokes, so on and so forth, and treat that deficit adequately by giving isotonic solutions. Hyponatremia, hypoosmotic, it can be because of euvolemic or a hypoosmotic cause. Usually it is H2O intoxication. You have some individuals at times who keep drinking a lot of water for some well-known reason for them. Renal failure or a specific entity called as SIADH, which is a syndrome of the inappropriate secretion of the antidiuretic hormone, or in some low-level thyroxine secretions. NL6 are notorious, and adrenal insufficiency. These could be the causes which are elephants in trying to cause this sort of a hyponatremia. And the treatment is, there's absolutely no treatment in this case. You got to restrict the water intake. That's it. And that will take care of itself. No need to use diuretics or any other drug therapy. Etiology of management of hyponatremia: if it is hypervolemic and if the urine sodium is less than that, Again, water restriction, which is classically seen in these conditions of nephrotic syndrome, congestive heart failure, cirrhosis, and water restriction. Why these things are being told is the whole crowd is maxfacial. These cases can come to you with as an associated comorbid conditions. You got to be very careful, because I personally feel maxfacial is a very delicate thing to be mastered, that particular art, because you do something and the patient goes haywire, the success story cannot become a success story. Your knowledge about the rest of the conditions which are beyond your anatomy should be well, so that you have a comprehensive approach to the pathology with an increase in the sodium is to be termed as hypernatremia whenever the levels are more than 145 or more than 140. Above 140, it starts ringing the bell for that something is going wrong somewhere. And usually again the signs and symptomatology are more or less similar for an increase or a decrease. The neurological symptoms, they result from dehydration of the brain cells. As the solutes concentration increases, the intracellular brain cells get depleted, they get dehydrated, and can give rise to all the things which we have seen over here. Blood urea nitrogen, creatinine, urinary sodium, all these point out to establishing your diagnosis of hypernatremia. A fluid deprivation test may be performed to distinguish central from nephrogenic diabetes. This is highly theoretical, seldom we do in clinical practice. Containing solutions. The commonest thing which you people see in your field is invariably maxfacial is involved because of traumatic brain injury. So you people are usually called because of the anatomy where your specialists are involved, in addition to the traumatic brain injury. So either you deal the case along with them, or once the patient is stabilized with the traumatic brain injury, then you people take up. But in the net result is, this can give rise to a lot of changes in the fluid shifts, and this particular hypernatremia can come as a disturbing comorbid condition for the maxfacial and landing up in something called as a diabetes insipidus. And you people should be able to detect that and then manage that accordingly. If it is due to isovolemic, the etiology may be due to skin loss, respiratory loss, or it can be because of again a diabetes insipidus. Diabetes insipidus plays a pivotal role in trying to make you arrive at a conclusion that if this is all happening because of a diabetes insipidus, and then